Certainly, as a specialist in pediatric cardiology, here's a focused summary on acyanotic congenital heart defects, CHDs, highlighting diagnostic findings and treatment modalities, particularly emphasizing drug names and classes for educational purposes. Atrial septal defect, ASD. Diagnostic findings, echocardiography, interatrial communication visualization. ECG, possible right ventricular hypertrophy, incomplete right bundle branch block. Chest X-ray, enlarged right atrium and ventricle. Treatment, medical management, rarely required. Surgical, transcatheter closure or surgical patch for significant shunts or RV enlargement. Drugs, prophylactic antibiotics for endocarditis in certain cases. Ventricular septal defect, VSD, diagnostic findings, echocardiography, pathological left to right blood flow, ECG, signs of LV and RV hypertrophy and significant defects, chest X-ray, pulmonary vascular markings, possible cardiomegaly. Treatment, medical management, diuretics, e.g. furosemide, ACE inhibitors, e.g. captopril, and inotropic agents, e.g. digoxin for CHF management. Surgical, closure via patch, particularly in cases of heart failure or significant shunting. Patent Ductus Arteriosus PDA, diagnostic findings, echocardiography, visualization of the ductus arteriosus shunt. ECG, left ventricular hypertrophy in significant PDA. Chest X-ray, increased pulmonary markings, enlarged cardiac silhouette. Treatment, medical management, NSAIDs like indomethacin or ibuprofen to encourage closure in premature infants. Surgical, transcatheter occlusion or surgical ligation for symptomatic or large PDA. Corktation of the aorta. Diagnostic findings, Doppler echocardiography, gradient across corktation. MRI CT to delineate anatomy and extent. Chest X-ray, 3 sign on aortogram, possible rib notching. Treatment, medical management, antihypertensive therapy as needed. Surgical, resection with end-to-end anastomosis, balloon angioplasty, or stent placement in older children and adults. Pulmonary valve stenosis, diagnostic findings, echocardiography, valvular morphology and pressure gradient assessment. Chest X-ray may show post-stenotic dilatation of the pulmonary artery. Treatment, medical management. Limited role, may use diuretics for right heart failure symptoms. Interventional, balloon valvuloplasty as the first-line treatment. Diagnostic findings, echocardiography, assessment of shunt direction and pulmonary arterial pressures, cardiac catheterization, definitive pressure and resistance measurements. Treatment, medical management, pulmonary vasodilators, e.g. sildenafil, bosentan, supportive therapy for heart failure. Surgical, heart-lung transplantation in select cases. For all CHDs, it's imperative to manage associated complications such as arrhythmias, infective endocarditis, and heart failure. Genetic counseling and regular follow-up are crucial for monitoring disease progression and managing comorbidities. Certainly, here's a clinical case focusing on atrial septal defect, ASD, a common acyanotic congenital heart defect. Clinical case, atrial septal defect, ASD. Patient profile, age, 4 years old, sex, female. Presenting complaint, parents report the child tires easily during play and has had slower growth compared to peers. History, medical history, unremarkable prenatal and birth history. Regular vaccinations up to date. No significant illnesses. Family history, maternal aunt diagnosed with a congenital heart defect, specific details unknown. Social history, full-time daycare attendee, non-smoking household. Physical examination, general appearance, petite stature for age, mildly dyspneic after walking to the examination room. Vital signs, HR 110 BPM, BP 95 60 millimeter grams, RR 24 breaths min, O2 sat 98% on room air. Cardiovascular, regular rhythm, fixed splitting of S2 heard during auscultation. Soft systolic ejection murmur noted at the upper left sternal border. Respiratory, clear lung fields bilaterally. Abdomen, soft, non-tender, no hepatomegaly. Extremities, no cyanosis or clubbing. Peripheral pulses intact. Diagnostic workup. Chest X-ray, mild cardiomegaly with increased pulmonary vascular markings. ECG, incomplete right bundle branch block, right atrial enlargement. Echocardiography reveals a 12 millimeter ostium secundum atrial septal defect with left to right shunt. Right atrium and ventricle are mildly dilated, no evidence of pulmonary hypertension. Assessment. The child is diagnosed with an ostium secundum atrial septal defect, contributing to her symptoms of exercise intolerance and failure to thrive due to increased pulmonary blood flow and right heart volume overload. Management plan. Referral, pediatric cardiology consultation for further evaluation. Intervention. Considering the size of the defect and the presence of symptoms, closure of the ASD is recommended. Given the child's age and the ASD size, transcatheter device closure is the preferred approach. Follow-up. Regular follow-up appointments will be scheduled post-procedure to monitor recovery and ensure the defect's successful closure. The focus will also be on monitoring growth and development. Family education. Parents are educated about the nature of the defect, the proposed intervention, and the importance of post-procedure care. Genetic counseling is also suggested given the family history of congenital heart defects. This case highlights the importance of early detection and timely intervention in managing congenital heart defects to prevent long-term complications and improve quality of life. Oral exam questions on atrial septal defect, ASD with answers. Question 1. What are the types of atrial septal defects and which is the most common? Answer. The main types of atrial septal defects include ostium secundum ASD, the most common type, located in the middle of the atrial septum. Ostium primum ASD, located lower in the atrial septum, often associated with atrioventricular valve abnormalities. Sinus venosus ASD, located near the entry of the superior or inferior vena cava. Coronary sinus ASD, rare, involving part of the atrial septum that separates the coronary sinus from the left atrium. Ostium secundum ASDs are the most common, accounting for approximately 70% of all ASD cases. Question 2. How does an atrial septal defect lead to pulmonary hypertension? An atrial septal defect allows oxygenated blood from the left atrium to flow into the right atrium, left to right shunt, due to the higher pressure in the left atrium. This extra volume of blood is then pumped into the pulmonary circulation, leading to increased blood flow through the pulmonary arteries. Over time, this can cause an increase in pulmonary vascular resistance and pulmonary arterial pressure, leading to pulmonary hypertension. If untreated, this may progress to right ventricular hypertrophy and potentially Eisenmenger syndrome, where the shunt reverses to a right-to-left shunt due to severe pulmonary hypertension. Question 3. What are the indications for surgical closure of an atrial septal defect? Answer. Surgical or device closure of an ASD is indicated in the presence of symptomatic patients, e.g., exercise intolerance, recurrent respiratory infections, evidence of right atrial or ventricular enlargement due to volume overload, significant left-to-right shunt leading to pulmonary overcirculation, paradoxical embolism or atrial arrhythmias associated with the defect, pulmonary hypertension, provided it is not severe enough to contraindicate closure, i.e., not in the setting of Eisenmenger syndrome. Question 4. Describe the typical auscultatory finding in a patient with an atrial septal defect and its physiological explanation. Answer. The characteristic auscultatory finding in ASD is a wide, fixed splitting of the second heart sound, S2. This occurs because the left-to-right shunt delays right ventricular emptying, thus delaying pulmonic valve closure without affecting aortic valve closure. The increased blood volume in the right heart leads to prolonged right ventricular systole, causing the pulmonic component of S2, P2, to be delayed and remain split from the aortic component, A2, across the respiratory cycle, unlike in normal physiology where splitting varies with respiration. Question 5. What are the potential complications of an untreated atrial septal defect? Answer. Potential complications of an untreated ASD include pulmonary hypertension. Increased blood flow to the lungs can lead to remodeling of the pulmonary vasculature and elevated pulmonary arterial pressures. Right heart failure. The increased volume load can eventually lead to right atrial and ventricular enlargement and dysfunction. Arrhythmias, particularly atrial fibrillation due to stretching and enlargement of the right atrium. Stroke. Paradoxical embolism can occur when a blood clot passes from the right atrium to the left atrium through the ASD, potentially leading to cerebral embolism. Eisenmenger syndrome. The reversal of the shunt direction due to severe pulmonary hypertension, leading to cyanosis and systemic hypoxemia. These questions and answers provide a comprehensive overview of atrial septal defects, focusing on essential aspects for a professional specializing in pediatric cardiology or preparing for medical licensing exams.